Welcome to the new Ortho Info podcast, a monthly series where board-certified orthopedic surgeons provide in-depth answers to frequently asked questions about bone and joint conditions, treatments, injury prevention, and more.
Welcome, everyone, to the Ortho Info podcast. I'm Dr. Mary Mulcahy, Chief of Sports Medicine at Loyola University Medical Center in Chicago and Editor-in-Chief of Ortho Info. Each episode of the Ortho Info podcast will answer a different question that we as orthopedic surgeons frequently hear from our patients. So in this specific episode, we are going to focus on the question, what can I expect if I'm having hip replacement surgery? And here to help answer that question is Dr. Neil Sheth, an adult reconstruction surgeon who is Chief of Orthopedic Surgery at Pennsylvania Hospital and the Abramson Family Endowed Professor of Orthopedic Surgery. Neil, welcome to the Ortho Info podcast.
Mary, thanks so much for having me. Excited to have this discussion with you.
Awesome. Thank you. I can't wait to share all this great information with our patients. So you are an adult reconstruction surgeon, and I would be willing to bet that a lot of people listening, a lot of patients out there, don't really know what an adult reconstruction surgeon is, because it's certainly not obvious from the name. So can you explain to everyone listening what it is that you do?
Yeah, Mary. So adult reconstruction is where you focus on hip and knee replacement. So 99% of my practice is taking care of patients who have arthritis, either of their hip or their knee, and they need a joint replacement, and specifically lower extremity, so hip and knee replacements.
Perfect. Thank you for clarifying. Because yes, there's shoulder replacements too, but obviously that's not part of what an adult reconstruction surgeon do. So that does. So that's an important clarification for patients. Adult reconstruction surgeons also, though, are not the only surgeons who treat hip problems, for example. Like, I'm a sports medicine surgeon, and sports surgeons take care of hip pain, some types of hip pain, but we don't really do hip replacement. So if a patient just develops kind of significant hip pain, they're having trouble getting around, should they go to you straight away to figure out what's causing their symptoms, or maybe should they start elsewhere, try to get an idea of what the diagnosis is, and then ultimately come to see you?
That's a great question, Mary. So, we get this question a lot. We see patients who may wake up with hip pain and all of a sudden they show up in our office and they really don't need our help. So like you said, there's different things that can cause hip pain. I think if someone has new onset hip pain, probably one of the best things you can do is get into your primary care doctor, get a hip x-ray, and that'll at least get a starting point of what could happen. So other surgeons or other doctors that will take care of hip pain, you have patients who may have a traumatic episode. They had a fall, they had some injury when they were playing sports where they fell on their hip, and now they may have something wrong with the actual bone, and you might see that on an x-ray. So there might be something that's from the trauma side that needs to be taken care of. Like you said, on the sports side, there's a multitude of different soft tissue structures around the hip that can cause problems in the hip, and that may prompt getting an MRI or some other type of imaging around the hip. And again, a sports surgeon may be the right person to see for that type of hip pain. And again, for what I see patients who have end-stage arthritis where people have lost the cartilage in their hip and now they're bone-on-bone arthritis, and that's when they get to the point of seeing me. So I think if you do have new onset hip pain, I think you can start out with your primary care doctor or a non-operative provider to get the first test or the first x-ray to look at your hip, and then from there they can figure out which direction you need to go in.
Those are great suggestions. Bottom line is see somebody, certainly, if the pain's not getting better. X-rays are really critical. That gives us a lot of information about the bones and tells us, like you said, about arthritis. And then a lot of times patients can start with things like physical therapy. They may get an injection into the hip, which, I'm sure at Penn and at Loyola, we have a lot of primary care sports medicine physicians who do ultrasound guided injections. And that also is a great way to start and try to decrease that discomfort. So those are all helpful physicians to see initially before maybe getting to Dr. Sheth. So in this episode, we really are focusing on hip replacement, which is an incredibly common procedure in the United States and really throughout the world. But for those who may not be familiar with that terminology, Neil, can you explain to us what a hip replacement is and what parts of the hip actually get replaced and with what, like what types of material or components, just to help them understand?
I think the easiest way for patients to understand this, and they're comfortable with this concept, is that when we think about the hip, it's a ball and socket. Okay, so you've got these two surfaces that rub against each other, and when you're born with this shiny white cartilage on both sides, and it makes it for a very smooth surface, and patients are able to get good hip motion without any pain. As patients get older and over time through wear and tear arthritis, as well as some other reasons that this could happen, where they start losing cartilage, you end up in a situation where you almost have a square peg in a round hole. So the two surfaces don't really mate as perfectly as they did when you were a kid. And so as a result, when we think about hip replacement, what we do is we make a small cut at the top of where the ball part is of the ball and socket, and we remove the ball, which is the part that doesn't fit anymore and doesn't really mate with your socket very well. When we remove that piece, it opens up space in the hip. We end up putting a small metal cup that, for the most part in the United States, we're putting in a cup that has a very porous metal on the back of it that goes up against your native host bone on the socket side. Sometimes we put screws in to hold it in place. Most of the times you don't need screws. And then you snap in a plastic liner into that cup. And then we work with the femur bone, which is the top part of where the ball part is of your hip. And once we've removed the ball, now you're looking at the inside of the femur bone or your thigh bone, and that bone is actually hollow. So we can actually put in a metal stem. And again, in the United States, most of the time we're using a stem that does not use cement, and we're actually putting in an implant where there's a metal surface that will be up against your native host bone. Your bone will grow into this. And then on the top of that stem piece, we usually put a ceramic ball head. So these four pieces together make up your total hip replacement. And now that ceramic ball head is now rubbing against that plastic liner. And that's what usually takes you out of pain because it restores your function, but now you're not rubbing bone on bone.
Yeah, that's fantastic. And important for patients to understand, basically, by doing this, you're recreating two smooth surfaces, right? And that cup is the new socket of the ball and socket joint. So just to help patients understand, but that helps tremendously with the pain. And so shifting gears just slightly, right? Our goal with this podcast certainly is to help patients understand what is a total hip replacement. And you just went through that very well. But we also want them to understand when is it appropriate to have this type of surgery. So can you expand on some of these things? Like what makes a patient a good candidate for a hip replacement? And what factors are taken into account when you're trying to make that decision?
Yeah, I think that's probably the most common question that we get from patients that come in with arthritis of their hip. When they say, what do I need to do at this point? Do I need to have surgery? If I need to have surgery, what surgery do I need to have? And if they're not ready, the question they ask is, how do I know that it's time for me to consider something? I think for a patient, it's important. If you have a diagnosis of hip arthritis, you want to try to maximize and do everything you possibly can conservatively before undergoing surgery. So the things that we may ask patients to do is we may ask them to start taking anti-inflammatories on an occasional basis. We might to help minimize inflammation and help their pain. We may also help them with regards to using physical therapy as an option in the first part. Part of that will help them with strengthening the muscles around the hip, also help certain muscle groups get stronger to help unload the hip so it doesn't hurt as much. Occasionally, we will offer injections into the hip, like a cortisone injection, again, which is like high-dose anti-inflammatories that we inject into the joint, not into the bone, but actually into that joint space, so that those two different surfaces that are rubbing together in your hip. And when you have gone through all of those things, and now you're bone-on-bone arthritis, and you can see it clearly on an X-ray, there are certain things that patients tell us that's very common, right? They have trouble when they're walking. They have trouble standing up from a seated position. They have trouble putting on their shoes and their socks because their hip is starting to get tight and they can't move normally the way they were doing. And so at that time, we're starting to think that if you have failed all the conservative measures for your hip arthritis, maybe you're considered a candidate and you should start thinking about getting a hip replacement. But again, the biggest thing for us is to make sure they have end-stage arthritis and you really lost that cartilage space in your bone on bones.
Yeah, those are all really good points. And I think that, I don't do knee or hip replacements as part of my practice now, but certainly we all get a lot of exposure during residency. But I think one of the key things is like patients know. They ask you the question of when will I know? But I think probably part of your response is like, trust me, you will know when you're ready, when functionally you are so limited that you can't get around. It's really impacting your day-to-day and having significant pain. And of course, you want the x-rays to, of course, support like having advanced arthritis, all of those things together. But I think patients really know when they come in and they say, Dr. Sheth, please, like I am ready to have this hip replacement. Just I can't even do the day-to-day things that I want to do. And many patients listening may think, well, I hear about hip replacement, and isn't that just a procedure that older people have, that older patients have? When are some situations where you might do this type of surgery in a younger patient?
Yeah, that's also a really good question because I think things have changed over the years, right? So I think back in the 1980s and 90s when they started doing total hip replacements in this country, you had to be on the older side and almost been in a wheelchair and being completely unable to walk at all before being considered a candidate for total hip replacements. And the big concern then was we didn't know how long these implants were going to last. We were still learning a lot about the bearing surfaces, which are like the plastic and the ceramic that I had talked about before. We were also learning about the best ways to get these implants to actually secure to the bone so that we have good fixation of these implants for a long term. And a lot of it, again, I think comes down to longevity. What we've figured out, though, is that over the last decade and a half, I'd say we're starting to see younger, more active patients who are coming in who are being considered candidates for total hip replacement because they've got the same x-ray as someone who might be older. They've got pretty severe arthritis. They've lost that space in their bone on bone now, and they're coming in with the same complaints. And we have definitely started doing total hip replacements on younger patients because we know that the longevity of these implants, they're lasting much longer. People are doing very well. And it's very different when you have a patient, say in their 40s or 50s who has end-stage arthritis. A total hip replacement can really change their quality of life. To me, some of my older patients, I'm actually more concerned about their safety. I don't need their hip to give out and then they fall and then they potentially break their hip or break something else, which could be devastating to an 80-year-old patient. But I look at my patients who are in that 40 to 60 range very differently, maybe with a different demand on the hip, but also can do very, very well with a hip replacement when indicated properly.
Yeah, those are all excellent points. And I think of all the patients we take care of in orthopedics, patients who have hip and knee replacements are among the happiest, right? That just like you just touched on it, that for many of them, it gives them their life back. And they've been dealing with this pain for so long. So it really is life-changing. It's incredible, when they get to that point and they have the surgery and realize how much more they're able to do. You've talked a little bit about the different types of things that you use, the materials that you use to do this surgery, but some people listening might have concerns about some of the metal, right? You talked about the metal stem that goes into the femur, into the thigh bone. And patients may have heard about potential metal allergies. What do you tell patients in terms of, what to be concerned about or when to think about these different things?
Yeah. For our patients, a lot of the metal on metal problems that they may even hear about either in the newspaper, in some article, on the nightly news, this was based off of having two intervening pieces that were metal that were rubbing against each other. I will tell you that most of the implants that are out there on the market, regardless of the company or manufacturer that makes the implants for the surgeon that you go to, they're all pretty much very similar. They're all basically made out of titanium, which is not what people are allergic to. There was a different type of metal that we were using specifically for the head, where I'm now using ceramic, and pretty much in the United States, everyone is routinely using ceramic for almost all hip replacements. That was a cobalt chromium type of metal, so different than the titanium that we use for the implants with regards to the socket or the stem. And as a result, most people have gone away from using that type of a ball head almost routinely. And then on the socket side, there used to also be a metal liner that was similar to the ball head that we were using before. That was that cobalt chromium metal. It was those two surfaces rubbing together that created problems. And so now I would say that no one is really using that routinely, and definitely not having metal on both sides for a primary total hip replacement. I think that is really technology that has gone away in the United States. So I think the issue of metal allergy is much less likely now, and something that, again, if there's a concern, you should talk to your surgeon about it. But I think this is not a concern of today. It probably was a bigger problem maybe 10 to 15 years ago.
Yeah, thanks for clarifying that, because I think even for, when I was in training, it was quite different than what's being used now. So thanks for clarifying that for the patients. So once patients have decided that they're an appropriate candidate, they're going to move forward with having hip replacement surgery. Now, the reality is you don't just show up the day of surgery, right? There's a lot that has to happen first, a lot of preparation. So can you walk us through kind of the steps that patients might have to go through leading up to their surgery?
Yeah, so if you see your surgeon in the office, you've decided with your surgeon that you've gotten to a point where your life has been really negatively impacted by your end-stage hip arthritis. And the surgeon and their team feels that you are a good candidate for surgery. There's a few things that kind of happen from this point forward. So number one, you may get some additional x-rays or imaging that's done because the surgeon may use these to help plan your total hip replacement, thinking about sizes of the implants that they need, as well as the position they want to put the implants in. Next, you're going to end up having a medicine doctor or a cardiologist see you before surgery to make sure that you're safe to have surgery. And part of that is sort of your medical history. Part of it is also, I think, up to the patient to make sure that you are trying to get yourself in the best shape possible before you undergo this surgery, which means really trying to improve your health, thinking about trying to really focus on things like stopping smoking if you're a smoker, making sure that your sugar levels are under really good control around the time of surgery. So if you have diabetes, that could be something. Weight loss is always very helpful because we worry about patients who are overweight and having issues with wound healing after surgery. There's certain medications that you might be on that you take routinely that you may need to stop a certain time before surgery. And again, you'll probably speak to the team that is signing you up for surgery at the time in the office, and definitely as you get closer to your date of surgery. And the other thing that's, I think, really important is to make sure that you are prepared after surgery with the right social support, if you have that available, to help you with the time of surgery. And again, I tell patients that it's helpful whether you live with someone. If you don't, is there someone close by that can help you, whether it's a family member or a friend? Is there someone that can come from out of town? Is there a different place that you can recover at after surgery? It's just nice to have somebody around when you're recovering from surgery, even if that person doesn't need to do very much. And then the other thing is to make sure that if you are going to choose the location where you're going to recover, then it's important to really make sure that place is ready for you to recover, right? Moving loose carpets out of the way, not having things in the way of like having furniture that's going to block you from walking comfortably, and basically making sure your home environment is ready for you to have surgery. So there's a number of little things that you got to think about. And usually I think our teams, and definitely I rely upon my surgical assistant and my PA to really help with a lot of those elements, in addition to our social worker, which will help patients get ready for the day of surgery.
Yeah, all those things are absolutely critical and really excellent points that you've raised. So it's not just like deciding to have the surgery, but then all of this preparation that goes into making it so much easier for them to recover. And how often is it, I know you probably can't just put an exact percentage on it, but how often is it just in general where patients would have to go to a rehab facility after having a total hip replacement to recover?
So I'll tell you, I think that in the last few years, there's been a big push to prevent patients from going to a rehab facility. Part of it, I will tell you that insurance companies are looking at it more for cost. For me, it doesn't matter to me as long as it's safer for the patient. I think for the patients that don't have social support, the patients that don't have people they can rely upon to be with them after surgery, I think it's very hard for a patient, especially an elderly patient, to recover after a total hip replacement and do everything on their own at home. And as a result, they may be a good candidate to go to a rehab facility. Now, actually, at our institution, we wrote a paper probably about 5 years ago where we saw that the complication rate was a little bit higher for patients who went to a rehab facility, because if there's something that goes wrong, there's a doctor that you're under the care of, but they may not reach out to the primary team to tell us there's something wrong. And now you show up back in the office at 2 or 3 weeks after surgery, and a decision may have been made on your behalf, which I would have done something differently. And I wish I had known 3 weeks ago, because we could have done a different course for the patient. That being said, I'd say probably less than 10% of my patients will go to a rehab facility. A lot of it is really based off of either their social support, or if they have a surgically complex problem that requires something more than just a primary standard total hip replacement, and the patient can't be fully weight-bearing after surgery, and it's a little bit of a different recovery, they may need a little bit more hand-holding, and they may need to go to a rehab facility before going home so they can be safe.
Yeah, really important consideration. So thanks for clarifying that. Can you explain for everyone listening, where does this type of procedure tend to be performed? So we think about surgery being performed either in the hospital. There's also kind of an outpatient surgery center, but where does this surgery tend to be performed?
Yeah, so I don't know how it is for you, Mary, but for me, I'm still working in a hospital. We don't have a surgery center that's built out at Penn. We're in the process of doing that, but I'd say probably 70% plus of all of the total hip replacements in the United States are performed at a surgery center or an outpatient facility. Back in 2020, this came off of the inpatient only list by the government, which means if patients are healthy enough If patients are surgically straightforward, then there's no reason they can't have it done at a surgery center. And I think the data is very clear for patients that they prefer that process and that experience as opposed to being in the hospital, because there is a facility that they do nothing but joint replacements. They've got a team that's fully set up for the entire process. They've automated the entire process to really make it so straightforward for the patient. And these patients come in the morning, they have their surgery done, and then within 3 hours or so, they're already back home recovering at their house. And so I think if you're a patient that has that opportunity and you're considered a good candidate to have it done in a facility like that with the right surgeon and their team, that's a beautiful place to have your hip replacement. If you are in a different category, you have a more surgically complex surgery that requires a different type of implants, a different type of approach, different type of sort of rehab after surgery, then it may not be worthwhile to have that done at a surgery center and you may need to be in a hospital.
Yeah, I think it's really incredible. I think that's been a huge shift in the past 10 to 15 years of the number of the hip replacements, for example, being performed as an outpatient, where patients come in exactly as you said and go home a few hours later. That really is incredible. And it's certainly, I think most patients, if they're able to, do feel a lot better recovering at home.
Yeah, if they can do it that way, and I think patients for certain prefer that. And we have patients who ask for it beforehand. And even though I work in a hospital, I can still send patients home. You know, I've got 6 hip replacements on for tomorrow, of which 3 of them should be going home early in the morning. And so we've just created the system in the hospital. But again, if we had a surgery center, I think it would be a little bit more streamlined because the expectation would be that everyone would be going home who had surgery there on a given day.
Yeah, that's incredible. But just in general, how long does a hip replacement tend to take? I know there are like different special circumstances, but on average, how long does it take?
On average, it takes less than an hour, right? So most surgeons and most teams that are used to doing total hip replacements on a routine basis, on a weekly basis, they're going to get this done in probably 30 to 40 minutes. By the time that they actually close the incision, put the dressing on, I'd say the entire episode takes about an hour for a straightforward total hip replacement.
That's incredible. And speak a little bit just to what can patients expect with regards to anesthesia? Like, is this general anesthesia, or are they getting a block? Is this spinal? Does it depend on the type of patient? Like, what general comments can you give about anesthesia?
I think this is something, Mary, that's also changed. I think probably when you and I were residents at that time, everyone was getting general anesthesia for most of these cases. I think the length of stay was longer, rehab was a little bit slower for patients, and I think everything has changed now. We're doing a much better job of giving patients certain medications before surgery to get them prepared for the actual surgical episode. And part of that, I think, I'd say 90% of my patients get a single shot spinal. Still a common question that I get from patients when they're signing up for surgery. But then I also make sure that they will meet the anesthesiologist the morning of surgery so they can go over all of the alternatives, risks, and benefits to either approach. I do think that the spinal is a little bit better for patients if they can tolerate it, because I think it's safer for them. They're breathing on their own, so they don't have a tube right down their throat. And this will give them some good pain control after surgery for the next 3 to 4 hours as the spinal is wearing off. And all in all, if the surgery is going to take 35 to 40 minutes, and by the time you're out of the OR, it's an hour, it's nice to have that in a much safer environment. But there are some patients that are not candidates for spinal anesthesia. Either the patient doesn't want it. Some patients have had extensive spine surgery before, so they may not be a candidate to get a spinal because they can't find the spot through all of the hardware. And as a result, the patient may need general anesthesia, but I think general anesthesia today is much safer than it was 15 years ago. Right? I think anesthesiologists are offering light general anesthesia. They have different medications. They're not really giving them a lot of narcotic medications or opioids, which can really snow them after surgery, and they can't really participate with physical therapy. So I think either option is good. My preference is a spinal when possible, because I think it is better for patients. But if you're not a candidate, I think it's absolutely safe to have a general the way they do it today.
Yeah, I think there's so many things to take into account, but nice to hear that in general, the most common type of anesthesia you're using for patients with this procedure is spinal anesthetic. And so fantastic to see how that has changed really in a relatively short period of time. And then after surgery, certainly a big focus and very important to the patient's overall outcome is their rehab and sort of that recovery in the postoperative period. So there are a lot of factors certainly that can impact your patient's outcome following hip replacement. You touch a little bit on pain control and opioids. Certainly, I think that's a concern for a lot of patients. So just in general, can you share some comments with patients who might be listening about what to expect, what in general is used to help control pain after surgery?
Yeah, so I think this is probably one of the biggest things that we've made a change in the last 15 years with pain control around total joint replacement in general, but even for hip replacements. I think back 15 years ago, if I were to think of how we took care of pain, is all we had were opioids. So we would give you some opioids, and if you had more pain, we'd give you a little bit more. And if you had even more pain, we'd give you a higher dose. And now patients had way higher complication rates and having nausea, vomiting, having an inability to go to the bathroom, and then their pain was not even under control. So what we figured out, I think, in the last decade and a half is we're using a lot of different medications that synergistically work better together to help get your pain systems tuned up before they get revved up out of control. And then we're not trying to catch up to your pain, which we weren't doing a good job of doing before. So we use medications like anti-inflammatory medication. We use medications, there's several medications that we use that help with pain, but also with nausea and vomiting, which is a very common thing that patients can complain about after surgery. So we've done much better with that. We give them pain medication that focuses on nerve type pain after surgery. We will give you a low dose narcotic medication also, but these are shorter acting medications, and you'll get a low dose of this after surgery as well. And at the time of surgery, I think we're much better at a lot of the soft tissue handling that we're doing around hip replacements today than we were even 15 years ago. So we're doing less soft tissue trauma at the time of surgery, which minimizes pain. And then there are specific blocks, either from anesthesia or even for us. I do a block inside the hip joint at the end of the surgery and inject a certain number of different agents of numbing medication around the hip joint where I know that a lot of the pain fibers are located, which I think will help our patients as well. And then after surgery, we're really trying to minimize the amount of narcotics they get or opioid medications. We send them home with an anti-inflammatory medication. And that's really pretty much all they're taking now. And so I would say that for most of my hip patients, at 2 weeks when they come back to the office, a lot of them say that they didn't take any pain medication at all. And it's kind of nice because that's not how it used to be a decade and a half ago.
Yeah, it has been absolutely incredible to see the change because when we were residents, patients were getting a lot more of that very strong pain medication, the narcotics or opioids, as you mentioned. And I think for some patients listening, right, they may have heard kind of the buzzword of multimodal pain management. What we mean by that is approaching pain from a lot of different aspects, as Dr. Sheth was talking about, using anti-inflammatory medications like Motrin and Aleve, and using some of the stronger pain medication, using some blocks or numbing medication during the surgery. All of these are different ways to control the pain, and together they work very well. So I think that's an excellent point that you made and has helped tremendously. That's incredible that patients come back 2 weeks after surgery and many times are not taking anything. So really amazing to see how effective that has been. And some other things in that period after surgery, right? First is just getting around, the basics of like getting around, patients getting up, getting out of the chair, getting out of bed. Touch on that a little bit. What do you tell patients about? When will they expect to just be able to get up, start walking? Do they need anything to help them? Do they use a walker? Do they ever use crutches? Do they use some type of device that helps them walk? And then what about physical therapy in that period?
Yeah, so I think that every patient's a little different, right? So I think my younger, more active patients who are better conditioned preoperatively are going to be able to do more early on. I think my older patients that are maybe a little more deconditioned may take a little bit longer to get there. But I tell them that to give themselves at least the first 4 to 5 days of a little bit of rest and let their body start healing. I'd say that most patients have the most discomfort in the first few days after surgery, but they're pretty happy with hips because the hip pain that they had deep in their groin is usually gone right away, and you've replaced that with a little bit of pain that feels like a bruise over the incision that you just made. I actually will place patients on a walker for the first 2 weeks, and that's more to protect them from themselves, because I think right around day 4 or 5, people feel really good and they say, oh my God, I'm just going to go to the Christmas market and walk for 5 miles because I feel great. And then that's the person that's going to call me 2 days later with a hip that's swollen and now they can't put weight on it and it hurts a lot. So I tell patients that, look, we're going for the long haul here. I want this hip to last for the next 30 plus years. And if that's the case, it's okay to give yourself the first couple of weeks to let your body really heal. And when I see you back in the office at 2 weeks, we can start advancing you a little bit further. The reality is that a majority of patients, by the time they get to 2 weeks, they've already dropped their walker at 5 days and they've been doing what they want to do. But I'm okay with them slow playing it a little bit. The aspect of physical therapy also is an important one. I know there's a lot of centers in the United States that don't use any physical therapy at all. And again, I think that my more conditioned patients probably don't need much therapy afterwards. Maybe the deconditioned ones do. But I also think that something that's important is that most patients who have arthritis in their hip, I'd say a majority of them have arthritis in their lower back as well. And over time, they have compensated one way or another. They've used their lower back to compensate for a hip that's stiff and arthritic and that doesn't move, or vice versa. And so once you do the hip replacement, now the hip is open and free to move, they're going to walk differently. And they're going to need a little bit of physical therapy, I think, to almost retrain their brain to walk right because they've walked wrong for some time. They're going to start seeing some different stresses on their lower back that they weren't seeing before. And I'd say most patients come out saying, oh my God, my back pain is so much better because now your back's now working hard for a hip that's stiff because your hip is no longer stiff because you had your hip replacement. But I'd let the physical therapist work with our patients to figure out what they need because I think everyone's different. And I'm not sure I'm good enough to understand there's small nuances between one patient and another with regards to how they were compensating before they had their hip replacement.
Yeah, really, really critical points and emphasizing that for many patients, right, that there is some benefit to physical therapy. But I agree with you. I say the physical therapists are the expert, even though I don't do hip replacements, but just in sports procedures, right? The physical therapists are the ones who decide the exercises, who know how to target it for that specific patient. So really, really fantastic point. And then what about just resuming life activities? What are some restrictions that you explain to patients, like you should expect this, you won't be able to do this straight away, or just restrictions they need to keep in mind, at least initially after the surgery?
Yeah, I think a lot of this, to be honest, I think for patients, they've got to really speak to their surgeon to get a sense of what their expectations are and what their limitations may be. I think surgeons have different personalities and different thresholds for what they accept after a total hip replacement. I think there's also different limitations based on the surgical approach you had. Sometimes your hip replacement may be done from the front of your hip, from the side of your hip, or from the back of your hip. And I think those have different limitations based on that surgical approach. But, my goal for most patients, and like I just said, for the first 2 weeks, I'd like you to rest a little bit and let yourself heal. As you start feeling better, as you start getting stronger, I really cut them loose, probably at around 2 or 3 weeks to start being able to do the things that they want to do. And I think patients are really pretty good about coming in and saying, well, when can I go golf? When can I go do this? When can I get back to work? I do this type of job as opposed to being sedentary and sitting all day. So I can also titrate amongst that. If I think that patients are doing something that is going to be a little bit more high risk, we may shut them down for a little bit longer and give them a little longer time to heal the tissues around the hip. But for the most part, probably somewhere between that 2 to 4 week mark is where people want to start doing more and more. And I'm okay with it if they're able to tolerate the activities and they're demonstrating good strength and good balance.
Yeah, amazing that as early as 2 weeks after this surgery, patients are wanting to start pushing it, right, with their activities and things they haven't done in such a long time because they have so much relief from their pain. So there's tons of research out there about hip replacements and outcomes and all that. But for patients listening, like, what can you share with patients about how long hip replacements last in general? What can they expect?
Yeah, I'll tell you, Mary, that's probably the other thing that's really changed a lot. I know when we were residents, we heard from the surgeons that trained us that, maybe you would expect 10 years, maybe 15 years on a good hip. And I'll tell you, in 2025, I'm still seeing patients who had their hip done in 1990 who are coming in now for the first time, and they've been pain-free for 35 years. The nice thing is that the new technology that we're using, the new types of plastic we're using, the new type of ceramics that we're using for those intervening pieces in a hip replacement, the new data shows that at 25 years, we're seeing absolutely no appreciable wear of the implants on the X-ray. So I truly believe that these implants are going to last for 35 years or longer. And that's what I tell patients now. So if I have a patient who comes in at age 70, I realistically believe that this implant may outlast that patient and they may not need anything else done for their hip in their lifetime. And that's the hope. So I think hips are going to last longer, and we're continuing to work on trying to come up with different materials and different surfaces that can rub against each other to basically have that really fine, smooth motion, but also something that's just not going to wear out. I'll tell you, Mary, I have probably one of the largest series of kids under the age of 21 that have total hip replacements because I'm so closely linked to the Children's Hospital of Philadelphia. And some of these kids, unfortunately, had some pretty bad diagnoses and diseases when they were kids, and they got big doses of medications that caused them to have hip disease. Some of these kids have syndromes that are very rare. Some of these kids have trauma. They fell, they broke their hip, they tried to fix it, it didn't work. And I will tell you that we just published my data just recently this past year with 100 kids under the age of 21. There's only one kid that needed a second surgery at 12 years. And that was because he had a very rare genetic condition where the bone did not grow into his implant. So I'm not even sure that's considered an issue with the hip replacement. It may have been more of the patient's biology. But so those are the extremes, right? So I'm thinking about patients in their 40s and 50s. It's still maybe the only implant that you ever get placed.
Yeah, that is amazing. That's also a huge change, and it's great to see that in a relatively short period of time and how technology has changed and how it's impacting patients' lives. Amazing. I have one last question for you, and this question actually could probably be information for a whole podcast in and of itself, but we'll just kind of scratch the surface with this. What happens if a hip replacement fails, right? I mean, first, how common is this? How's a patient going to know if something's not quite right, and what symptoms should they be aware of?
Yeah, I mean, thankfully, hip replacements, I don't think fail that often, especially if they're coming out of centers where a surgeon's doing a lot of them. And so I think when you do a lot of them, you have the ability to reproducibly do this operation and put implants in the right spot, so your complication rate is fairly low. But what do patients need to pay attention to, right? If you have pain, you got to think about when you're having pain. And when we think about pain in the hip, it's typically pain in the groin, which kind of is really centered over the hip. And then if it's in this sort of top part of your thigh, that can also be the bottom portion of your hip. What I tell patients is, number one, if you're thinking about you're having pain in that area, are you having pain all the time, which means whether you're walking or whether you're sitting or whether you're at rest? That is concerned, because then my biggest thing I would want to make sure in that patient is that they don't have an infection in their hip. Then the second thing is, are they having pain in specific times? Doc, when I'm sitting there, I have no pain at all. When I get up and I start moving and I start walking, I start having pain in my hip. And then I walk a few steps and that pain starts getting better. We call that startup pain. And that may signify that your implants are either loose or something is changing in the component position that was already put in. And then if you have a situation where you had something traumatic happen, and now all of a sudden, so you fell, and all of a sudden you're unable to get up and you're unable to bear weight on your operative leg. Now we're thinking something more acutely happened, like either you broke a bone around your hip replacement. It's rare and very unlikely that you broke the actual hip replacement itself, but the bone around it, or did you dislocate your hip? And those are the things that if that happens, I think the patient has to go to the emergency room because they need an x-ray at least to see what's going on and see if there's something that's acutely different in their hip today than it was yesterday, and something that might require more treatment and something done sort of acutely now as opposed to waiting for it.
Yeah, thanks for that. I know this is it's a big topic, but thank you for kind of very concisely summarizing some things that patients should keep their eye out for and where they should bring attention to their surgeon or their physician to get more in-depth evaluation if they're concerned about that. So this has been a fantastic discussion. I'd like to thank our guest, Dr. Neil Sheth, for helping us understand what to expect when having a hip replacement. We hope you enjoyed the conversation and will join us for future episodes.
This has been the OrthoInfo podcast, brought to you by the American Academy of Orthopedic Surgeons. Production and editing by MK Quinn Media. You can find the OrthoInfo podcast on orthoinfo.org and wherever you get your podcasts. Like and subscribe so you won't miss new episodes, and visit the OrthoInfo YouTube channel for full video podcast episodes and shorts. The views and opinions expressed by guests are their own, and their appearance on the podcast does not imply an endorsement of them or any entity they represent by the AAOS. Reference to any specific product, device, or service during this podcast is for educational purposes only and does not constitute endorsement or recommendation by the AAOS. OrthoInfo, expert musculoskeletal health information provided by surgeons, trusted by patients.